Welcome to the Kaleidoscope, Healthcare in a Diverse America, from molecule to market, with your host, Sheila Thorne. Each episode highlights healthcare leaders and patients of color to discuss culturally, linguistically appropriate strategies and services. You can find this show on all major platforms, including YouTube, LinkedIn, Apple Podcasts, Spotify, and on our website, SheilaThorne.com. Now here's the host of the Kaleidoscope, Sheila Thorne.
Hello, and welcome to the Kaleidoscope. We are delighted to have you with us today to talk about a very controversial topic, which most people wouldn't think is connected to health, but it indeed is. June is National Public Safety Month, and in our last episode, we had two of the nation's leading law enforcement professionals, Commissioner Giles H. Shipp from the National Organization of Black Law Enforcement Executives and NYP Detective Raymond Ramos, who both shared with us their jobs in keeping the public safe. And they were also giving us insight as to the impact of violence on the committee from a community policing perspective. Because there's no doubt that the murder of George Floyd, COVID-19 pandemic, thrust us into a world of gigantic commitment to police reform and how that impacts communities. This episode today couldn't be more timely because on Tuesday, the United States Surgeon General, Dr. Vivek Murthy, nation's top doctor, issued a proclamation that declared gun violence a public health crisis. And here's what he said. People are scared in many communities I visit around the country to do normal things like to go to school, to go to the grocery store or work. And they're worried about the risk to their life. Well, they're also scared about healthcare, how to get to a healthcare facility, how to exactly do what doctors prescribe in terms of exercise, walking in their community, kids sitting out on the stoop in front of their residence or playing in the street. All of that impacts their mental and physical stability. Murthy also said there is broad agreement that gun violence is a problem, citing a poll last year that found more Americans worry about at least sometimes that a loved one might be injured by a firearm. People want to be able to walk through their neighborhoods and be safe. So safety becomes a critical component of the social determinants of health. There are 5 pillars to the social determinants of health issued by the CDC. They are education, access, and quality, healthcare and quality, neighborhood and built environment, as well as social and community context and economic stability. So you can't avoid it. Safe neighborhoods, safe communities are critical to health. And if you, as a healthcare professional, aren't at least acknowledging or addressing the patient journey, especially patient journeys of color, and looking at the world through their eyes as they move around in their community, you are missing a critically important component so that you can reach out and engage effectively. If you are not of an ethnic segment and you are designing strategies to reach out to communities of color and you do not address public safety, you are marketing in a mirror. You need to reflect the attitude and the lived experience of people of color. Well, we have before us today an expert in this field, and it is an honor for me to bring to you a colleague, and I'm pleased to say and privileged to say a friend, Dr. Rahn K. Bailey, a forensic psychiatrist. Let me tell you about Rahn. Dr. Bailey served as the 113th president of the National Medical Association, which group representing 50,000 African-American physicians and their patients. In 2006, he was selected by his peers as the NMA Physician of the Year after his work in Houston during the Katrina hurricane crisis. He has been an advocate within the field of psychiatry, serving as the chairman of the membership committee of the American Psychiatric Association from 2014 to 2018. He was selected as the program chair of the American Academy of Psychiatry and Law and the co-chairman of the Commission to End Health Disparities with the American Medical Association in 2012. Currently, Dr. Bailey is chairman of the Department of Psychiatry and assistant dean of community engagement at LSU Health Services Center in New Orleans. He served as the chairman of the Department of Psychiatry of Meharry Medical College, one of our premier Black medical teaching institutions, and Wake Forest Medical School. He was awarded the Resident Research Award by the National Medical Association for his work on non-A, non-B hepatitis. Subsequently, he completed a fellowship in forensic medicine at Yale University and graduated and has practiced clinical research, academic, and forensic psychiatry for over 23 years. He's published 2 books, and we are going to talk about one of them. And we clearly know that this gentleman is an expert. He's trained in adolescent adult forensic work, and he has conducted over 1,000 evaluations and been deposed or testified on over 100 occasions in 7 states. Well, it's clear to me that we are bringing to you an expert, not only in forensic psychiatry, but specifically in violence. Please welcome Dr. Rahn Kennedy Bailey. Okay. Hello, Dr. Bailey. Welcome.
Hello. Thank you very much, Sheila Thorne, for inviting me. I really appreciate the opportunity to join your podcast today. Very happy to have worked with you, as you point out. I think extremely well over the years. Admire you and your work, your compassion, I think, for our community and all communities really matters, particularly, I think, for the mental health issues that certainly are important, I think, in our day. So thanks for having me. Look forward to today's discussion.
Thank you so much, Dr. Bailey. Not only has the Surgeon General declared violence as a public health crisis, but the American Public Health Association did as well in 2018. So it's clearly there is a connection between violence and mental health. And so, Dr. Bailey, the first question I have for you is, how does violence affect communities? We often think about the individual, and we know that that person needs help, but does it go beyond that?
It really does. I think first and foremost, violence is a consequential issue in all of our lives. As you pointed out earlier, persons who have been victims of violence, those who know individuals who've been victims of violence, and those who live in communities where others may have been victims of violence, all may experience similar feelings of fear, fright, discomfort in where they're going to go and what they're going to do, and it may adversely affect them living their lives in a normative way. So these are concerns, I think, for all of those in our society, not just limited to certain individuals, certain groups, or certain locations. We should look at it that way and develop large-scale, comprehensive, so-called public health approaches to address solutions.
Very well said. And I think you and I have talked about this over the years because there are many dimensions to mental health and to violence, domestic violence, drive-by shootings, mass shootings that unfortunately our country has experienced far too often in recent years. So I guess my question is, because we are focused on people of color, does violence affect communities of color differently than the mainstream population?
I think it does. Unfortunately, in my career, we've been involved, as you pointed out, in this violence prevention scheme for some time, certainly over a decade. I've been a psychiatrist for over 3 decades, but really focused in this area, I think, for the last 7, 8, 9 years or so. I think there are 3 issues that are relevant, I think, for your audience to be mindful of, and how violence, I think, disproportionately affects communities of color. First and foremost, the long history, I think, in our country of being a pro-gun country, and every person a man for himself, and you're gonna have your own gun and defend the risk of the bad guys from outside, has remained over time. But unfortunately, all too often, the bad guys no longer are the British from 200 years ago, but very often ethnic minorities who live in our own cities and not our own communities currently. And that's an unfortunate reality of where this problem, I think, started and how it's actually grown over time. Many have learned that you could use a gun to enforce your way and your will on individuals, especially those who may have less people, less power, less likely to have access to guns and resources to defend themselves. All too often, those have been minority communities throughout our country. In addition, I think it's also true that the issue regarding gun violence is also problematic because many communities, I think, often are over-policed and underprotected. You and I have friends, I think, on the East Coast in New York that make the argument that some law enforcement officers and settings that should be there to protect communities very often hunt in those communities and choose strategies to hurt them and use of the gun. And a violent means all too often has been the arbiter or the leverage has been used, I think, to do so. And the third thing I'd make a point is that I don't think we've received adequate, let alone optimal, healthcare interventions to address what often may be healthcare problems. If a person has depression or anxiety, I'm a psychiatrist. If they are under some degree, I think, of stress or difficulty in their interpersonal life, their work and education and economic or financial concerns, all too often that leads to behavioral difficulty. That if you don't know how to manage it, if you don't have good conflict resolution skills as an individual or as a group or a family or a community, all too often people are too quick to reach to an end result that may be a gun or a violent means versus something that's non-violent that may solve or address the issue or the problem. So I think all three of those themes are relevant in my career in addressing why gun violence has been a bigger problem, I think, in our community.
My goodness. Well, you hit on something that I know we're going to discuss, and I think it's right to bring it in now, and that's stress. We all experience stress in one way or another on a daily basis for a variety of reasons. But you are the one that enlightened me about a specific category of stress, race-based traumatic stress. That was new to me. And you mentioned in one of your presentations, I heard that there are more people of color suffering from PTSD who've never been on a battlefield. Right. So that's just every day. So tell us, what's the difference between the ordinary stress we all experience and race-based traumatic stress?
Well, it's timely. And I think we all are learning more about it currently. And I'm certainly trying to learn, understand more about it going forward. But a few themes are relevant that we do know. This issue of race has been a consequential issue in our society, not only for years and decades, but decades and centuries, not just in this country, but in many other countries as well. All too often, issues of race predate interpersonal conflict. So based on my race, somebody interfaces with me in a certain way. We all know the story if a policeman stops you, if you're concerned about how they're going to engage with you before you can quickly share with them what your background is, or if your college education, if you will, or how much money you have, or where you live. All those issues then play a role, and they really shouldn't. If you broke a law, you get a ticket. If you did break a law, you should get a ticket. You shouldn't have to have these additional variables related to you that allows the person to see you differently than only a person who has a different color skin. The issue of race-based trauma and stress falls along that line. The idea that the stress a person feels is not just stress that we may all experience, because life is difficult and money problems, and you got to take an exam, and you're trouble at the job with your boss, and hurricanes and disasters, the place where I am. But if the stress is due to the fact that you're being mistreated or misunderstood or misidentified, in your opinion, it's your perception that is solely based on your race, which is something that you cannot change. That creates a very different type of emotional trauma, in my estimation.
That's fantastic information, and something that people who are not of color might be difficult to relate to.
Absolutely. And that's why we have to have these conversations so that persons can learn to put themselves in other people's shoes.
Exactly. The Native American community has a saying, walk a mile in my moccasins before you judge me. So how we see the world is very different from someone who's not of color. And yet people seem to feel like we're past that. Okay, we had a Black president. We had Martin Luther King Day. We had Black History Month. What's the problem? So why is it that non-white people, or should say white people, don't understand the stress that people of color live under every day?
It's a tremendous question. I'm the first to say I don't have a good answer for it, but like many people, I have a lot of experiences and opinions that I share with you, that this idea that there's a post-racial society after the election of Barack Obama, I think in 2008, he was president to 2016, has been a surprise to so many of us, because many of the challenges that persons have experienced, in their opinion, because of their color of their skin, in their opinion, have not really changed in many regards at all. Many of the areas of unfairness with law enforcement, as we discussed earlier, much of the unfairness, I think, in some government institutions, how rules or laws or policies are made or enforced. I'm in the South now, and some of the southern states have laws that are very different than northern states or eastern states, or everything from, open carry of guns to what you can do in schools to, issues regarding how individuals are managed when there's some difficulty, I think, in the legal system. All of those challenges create, I think, a cause of concern and a red flag in the back of the minds of persons who think they're being unfairly disposed upon and mistreated and treated, I think, in a secondary manner, a deleterious manner, because of their race. Again, the issue of race is so important because it's a variable that we really cannot change. It's not an issue that somebody's mad at me because of my action or my behavior or what I did or didn't do. I am this color, my skin always will be. And if a person solely interfaces with me in a negative way because of that, that has an adverse impact on me and my own self-esteem and my own internal identity. Those are the issues that people tell us in individual therapy.
Deep, very deep and profound. Okay, so now, Dr. Bailey, connect race with health. If you have diabetes, if you have cancer, if you have respiratory illness, COPD, if you're suffering from, what's the connection between stress and health?
Well, there's a huge connection. The reality is we've had outstanding data for decades now addressing how racial concerns adversely can affect certain people's health. Early in my career, we used the term health disparities. As you mentioned, on my first book in 2013 was on health disparities, and I wrote it looking at the Obamacare ACA law that was came out in 2012 or 2010, and your Supreme Court approved it in 2012. And my thinking, I was very excited, naively, that as a researcher and a scientist who had done a lot of work in that area, we'd actually finally move toward having parity in the area of mental health. And because of that, we would probably have less health disparities. Now we fast forward and we use the term about a decade later, health equity, many of the same concerns. The idea that when things are very similar over time, why might one group have worse outcomes than others? I saw some data a few days ago. There's a lot I can say in that space, but the data point I want to share with you and your audience that's unbelievable to me is in 1850, Sheila Thorne, not 1950, my friend, 1850, pushing 200 years ago, 175 years ago, the average African American lived to age 22. Average white American lived to age 27. Clearly, all persons live much later now than longer now than before. But the fact that then there was a 5-year gap in age length of life, and now there's a 5 or 6 year gap in age length of life, probably 67 to 72, is shocking to me, because the reality is, although overall we've done much better, Americans and the like live much longer, the fact that we still have disparities is that's probably a man-induced issue. That has to be considered based on what doctors do, what healthcare operations do, because the color of our skin should not change, I think, length of life based solely on the medicine and the medical interventions. The issues very often are sociological. They're how people think about issues. What tests do the doctors prescribe for you? How are the doctors, how are the, what's the assessment of the rules? We now know now that for years, and nephrologists, for example, have used differing scales for what's a normal kidney function in a black person than a white person. And that probably was not based on empirical data, and probably over many years harmed African Americans, that incorrect misunderstanding of how one should assess that data. There's a myriad of examples like that. That's just one. We have in psychiatry as well, more blacks being psychiatrically civilly committed against their will into a psych hospital with the same behavior that somebody else may have, and they get treated clinically versus being involuntarily committed. So a variety of variables that come into play, but the fact that consistently in our healthcare entity, we make decisions that are more adverse to African Americans than other Americans is objectionable, and we have to call it out for what it is and work to change it.
Excellent, excellent. And that obviously applies to the Hispanic Latino community, to various Asian segments, and particularly during the COVID pandemic, the Asian hate crime spiked. So clearly it goes across the board with people who look different. So now, are you telling me that doctors are racist?
I clearly think that being racist or having decisions that are based on somebody's race can happen in any profession. Physicians like me, lawyers, engineers, plumbers, architects, accountants, and what have you. Clearly, there are some examples that are very specific of how issues have occurred in our country where doctors, even government-based doctors, have made decisions that most in society and medicine believe would not have been made had they been making decisions on the backs of people who are not African American. None more discussed than a so-called Tuskegee syphilis study. I read the book Bad Blood when I was a sophomore in college back in 1984. For those who are not aware of it, it was this idea that the government was conducting a study trying to figure out where might there be a concentration of people with the disease syphilis that they may be able to study to try to get an understanding of how might we be able to develop treatments for it. And that's the nature of how science works. It's a long story, but I think to cut to the chase, one clear responsibility of scientists, doctors, we involved in any study, once you develop a treatment that works, you so-called break the blind and end the study. Because at that point, every human being wants a treatment that works. No one wants to be part of a study to find out what might work.
Yes.
We call it breaking the blind. And the reality is, in 1952, about 20 years after this study started in 1932, we got the treatment penicillin, and those 300 or so 100 men were not told in Tuskegee, Alabama, Macon County, Alabama, that there was a treatment for syphilis. They were continued in not being treated with the better treatment. They were on something that was not curative, like penicillin, but was supposedly something to kind of help decrease your risk. It was called silver nitrate, and that lasted for 20 years, where they were not told the truth and were not treated correctly from 52 to 72. I would argue, in my entire 34-year career as a physician, I finished med school in June of 1990, that particular issue or that particular study has been, whether people know the details or not, they know about it. Yes. And they've talked to me about that repetitively, Sheila Thorne, throughout my career. So it has had a deleterious effect on research in our country. Many Blacks don't trust the government when it comes to healthcare because of that issue. Many people who are not African American, you mentioned the Hispanic community and the Native American community, and other communities also begin to appreciate that if that could have happened to African Americans then, these same kind of things have happened to other groups later on. You mentioned the Hispanic community. We tested the birth control pill in Puerto Rico. We didn't test it in the U.S. City or state to figure out how risk was going to cause for young women. So we just had too many of these, and they need to stop. And they won't end without proper education and an ongoing narrative that America as a government and physicians as a healthcare entity must treat all individuals fairly. If you do so, then we would not have to have a consideration of whether somebody's racist.
Amen. Amen. You know, you mentioned that book, Bad Blood. And when I read that book, I started working in the multicultural space. It was really troubling. And I took the time to track down James Jones, the author, a white investigative reporter who took on this task, wasn't even a healthcare professional, but certainly someone that saw that there was something really very wrong with that. And how could we not have that happen again? He's an incredible speaker, and it's well worth the read. Not to mention Medical Apartheid by Harriet Washington, who came out recently talking about the research abuse that these communities have experienced. And then Dr. Bailey, the American Medical Association, on the part of physicians, calls this unconscious bias when a physician, regardless of their race or ethnicity, has race as a factor. Is all of it unconscious?
No, I think that some is more likely to be conscious or intentional, although we think that some may be unconscious, if you will. We call it subconscious or unintentional. I think that both features are in play. There's a component of individuals who really believe that hurting other persons is the best thing to do. It's fraudulent. I think it's criminal. And as a physician, of course, I think that it's remarkably untoward in any profession, including mine. Some would argue that probably a larger group of persons may not think what they're doing is intentional, but if they've been acculturated in a negative way for a long time, some for a lifetime. If I, for example, was a man who always thought that all men were better than all women, I might indirectly make decisions in my healthcare determinations that put women at a greater risk. I'll give you an example. Some of your readers or listeners may have heard of what's called the Framingham study.
Yes.
Goes back 40, 50 years now. I was outside of Boston. This big study on heart disease. We still make many decisions in healthcare now based on results from the Framingham study. And Framingham excluded women from being in the study. And the concept was that on one issue, you would want women to be exposed. Either A, women didn't have the same heart risk as men, which wasn't true. Women die of, the one cause of death in men is heart attacks. The one cause of death in women is heart attacks. So we have every need to know what are the healthcare indices of heart disease in women as in men in our country. But it also could be that we were biased because the issue that women at different ages may have been in the midst of being in potential bearing years. But we have to figure out ways to work through that and work around that, not to allow all women to be excluded from studies that can particularly affect them, including the issues regarding the heart. So that's another example of how we've got to think ahead of the game in organized, government-funded research to ensure we're doing what's best for all members of our society, not only some groups, whether it's race or whether it's gender.
So true. And obviously the work I have done over the years in the pharmaceutical, biotech, and medical device industry, who obviously this is not their job for public safety. However, if they don't recognize this and are aware of this, their messages, their messengers, their strategies may be off. You've got to walk in the shoes of the end user of your product to determine how best to reach that one. But let's switch for a minute to gun violence, something that's been a specific interest of yours for a number of years. Sarah, would you pull up the slide, please, to show Dr. Bailey's book? The CDC says that 53 Americans a day die from gun violence. So that's a unique part of this violence epidemic that we're experiencing today. What was your reason for writing this book, Dr. Bailey?
Well, thank you for giving me a chance to kind of discuss it. It's really the quintessential question I think right now in my career thus far. Again, I've been in medical school in 1990, so I've been a doctor for 34 years, a practicing psychiatrist for 30. So I've been around the issue of violence prevention my whole career. Psychiatrists, by definition, one of the first things you learn to do is assess someone who may be at risk of violence, most commonly to themselves if they're suicidal, or they can be homicidal as well. We call that civil commitment, where they can put you on a locked ward and make sure your relatives take away the weapons or guns and put you on some medication for treatment of depression so that your thoughts will change before you actually get out. So the issue of violence consideration has been a part of what I've done for a long time. I trained in forensic medicine, which is a specialty area that addresses a lot of concerns that are legal. Violence isn't the only one, but it's one of the big ones. So I spent time on what I call the academic aspects of forensics. Did grand rounds on confidentiality and work on capacity, informed consent, things of that nature.
Yes.
Spent a lot of time in that setting, doing evaluations and writing reports. As I was doing evaluations and writing reports over a decade or more, I began to appreciate how different my experiences were in assessing individuals for what I kind of read about them in the past. You get to a hospital or a jail sometimes and evaluate somebody, and you think that, you're making an initial assessment, and you're reading so much about an individual, and you show up to see them, and they look, much different, much less at risk, much less violent. So there was a disconnect in my head in how we as a society very often engage, I think, in that whole kind of process. What particularly happened was in summer of 2016, a friend of mine, Bacoley Johnson, chairman of the med school at University of Maryland in Baltimore, honored me by giving me, selecting me as what they call the Dana Lecturer. Most med schools have one big lecture every year. Yes. Everybody comes, and some company or some family has donated money to support it. And he wanted to talk on gun violence because Baltimore, where he was, and Houston, where I'm from, had these huge problems, I think, with gun violence and we call qualitative violence. I spent 6 months, Ms. Thorne, researching it to get ready for it. Gave the talk in January of 17. It went very well. And at that point, I think I had written a book, just preparing and kind of really getting ready, because there were so many issues in play that I understood. So since January 17, the better part now of 6-7 years, I've been involved in this, writing about it. I've written another two books about it now. I'm writing my third book about it now. We lecture on it quite a bit. And I think that the take-home messages, the 5 big issues for your audience are: one, there are just too many guns. Yes. And no matter how we talk about it, and folks say Second Amendment, I like to criticize Second Amendment, you just will not have a society with less violence with so many guns. More guns than people in America. 350 million people, 4 million guns. Secondly, the guns that we have are too powerful. They're all magazine. They call high magazine, capacity. They're all machine guns. It could be a small little gun. It's not a 6-shooter. It can shoot 60 bullets in 3 seconds versus 5 or 6 or whatever. So people being shot at don't have a chance to hide or protect themselves or get away. Somebody walks into a mall or a grocery store or whatever, and you start shooting bullets everywhere. It's hard to have access to get them, hold them down, or to stop them. So we have more qualitative at-risk violence because of the power of the guns. The third thing I found out, though, is that we also don't do enough research in the area because of the so-called Dickey Amendment. Going way back 20 plus years now, Dickey was a congressman in Arkansas that made this big push that the government really didn't want to hear results of what I call gun research that might show that what we really need is what I call gun reform. And that's objection what I mean. We wouldn't want politicians making a decision that they don't want to have results that might show if you eat too much of the wrong food, it's going to hurt you, cause obesity or cancer. I think that you have to do research, We call it the null hypothesis in science. You have a guesstimate, you do research, and let the results fall where they may. And the fourth thing is we should use the research that we actually have. And I'll end with this. I think that society must know, and I thank you for giving me the platform to say it, that we have research now and technology that could decrease gun violence. The biggest issue is the so-called biotechnology. If I was going to buy a gun, and Second Amendment allows you to have one, I'm not against the Second Amendment, so to speak, that gun can be programmed and only work for me with my fingerprint, kind of like James Bond on television, which we think would decrease people breaking your house to steal your gun and then using guns bought illicitly, I think, in the cause of qualitative violence. So all four of those issues, I think, come into play that I talk about in the book, that all have some potential to decrease overall qualitative violence in our society.
Amazing. And how can people get your book?
Well, we're on Amazon. We also have we came to Westport, and I can certainly put the number up, if you will. Thank you so much for the opportunity. We've had a lot of success. That book has been out since 2018. The domestic violence book came out in 2021, and my follow-up on domestic violence book should come out by the last quarter of 2025. So we're putting a lot of work in this space. I'm recruiting some of the young researchers like myself to really get involved in this. We're trying to find the overlap between depression and anxiety, and rather than having a clinical response due to clinical treatment, people respond violently, aggressively. That's the only avenue that they actually have. Too many people have access to a gun, but don't have access to a doctor or a psychiatrist or a clinician to let talk therapy help them get many of these things kind of off their chest. I love saying on these education shows, so again, thanks for having me. I'm a 60-year-old, pretty much African male now, and I laugh how often folks have said to me in my life, man, males or black males won't go to the doctor, won't talk to the psychiatrist, they keep it all themselves. Not true. I cannot get black males to stop talking to me.
Wow.
We have to treat individuals of all types in a way where it's our responsibility to hear from them, not them to find ways to make it easy for us in that setting as professionals. It's also our opportunity to recognize that people need a space, a space where they feel safe and comfortable talking and telling you what matters to them. That decreases anxiety in general by kind of getting it off your chest. And you hope in a 1 hour session, if you can make 3 very brief, very moderate considerations, I like to call them, rather than recommendations. We don't give advice. We just have a person use the strategies that they already have in therapy to move to making better decisions that are much more likely to be conflict resolution oriented and less likely to be violence oriented and responding to difficulty.
Amazing. So there is most definitely a connection between public safety, mental, physical, and spiritual health. There's no question about it. The data are there. You've given us some few snapshots, but there's certainly more there. The other thing that I think we need to realize is that you have to be aware of what impacts the patient on a daily basis, not just what they eat, not just how much they exercise, but what is their spirit, their mindset, what's their community and neighborhood like. No, it's not your responsibility, doctor, to make the neighborhood safe, but it should be your responsibility to help your patients understand how violence has affected them, generational trauma, race-based stress. That's the lived experience. And so like the top doctor, the U.S. Surgeon General, he suggests that doctors should talk about gun violence with their patients, especially if they're in inner city communities where this is more likely to occur. Do you agree with that? Is that
I do. Early in my career, we talked a lot about what we call the 5th vital sign, pain. You go to med school and the age-old medical school, you go check somebody's blood pressure and their heart rate and their weight and their breathing respirations. So the big 4. So the 5th vital sign was pain. Ask about pain. I now say the 6th vital sign is issue regarding violence.
Wow.
So many people at risk, as this discussion started today with. Many individuals who historically we thought were not at risk, women. Early in my life, that is my career, there was just this unwritten rule that you wouldn't hurt a woman, let alone a senior level woman. If you were going to fight somebody, you'd fight, man on man. And my unfortunate reality has been that may not always be the case. But for one, if you go into a mall or a theater or a school and you shoot, openly, you don't know if you're going to hit men or women, boys or girls. But also, I think that what you hear from too many persons who engage in this unrequited just exposure to, comprehensive violence, they're not really thinking at all. They're not thinking about who they're shooting at. It's just something about what's happening inside them emotionally and internally, where the shooting is kind of action. Think about the guy that's shooting in Las Vegas.
Yes.
And he shot 8,000 rounds from a 40th floor of a big hotel after barricading himself in so people couldn't get to stop him. It only lasted 8 minutes. I think he hit 500 people. He killed 50 people. That person's not thinking about who they don't have a motive. They're not mad at any one particular person or one particular group. With a group that large, you aim just to cause, destruction in as large a swath as you can. There's no reason or rationale. Therefore, the typical strategies we tend to use to try to stop violence don't work in those type settings. So again, we should decrease the number of guns, and we should also go to a long way to decrease people at high risk. The idea in our country, there's a lot of laws in all 50 states. There's a law to block a person who has mental illness from getting a gun. I agree with that. I'm not against it. But one data piece point that I think most Americans don't know that is a bit contradictory is that the persons who have mental illness are not the ones most likely to use a gun to hurt somebody. The three variables that are most likely to be involved in somebody who uses a gun to hurt someone is somebody who has used a gun in the past to hurt somebody. So we get that right. If you go to prison, use a gun, we can't get a gun again. Although recently the Supreme Court had to get involved in whether somebody with a history of domestic violence could buy a gun again. In fact, we've been discussing that. I think it points out how upside down much of our thinking is in this regard.
Yes.
The second group, though, are persons who actually have been victims of violence.
Yes.
The third group, persons who actually have had alcohol or drug problems over time. So we should be as concerned with persons with arrested for DWI having a gun in the future as those who have had mental illness. So I think in part we have bias, Sheila Thorne, against those who have mental illness. We're very quick to make laws to block them from access to weapons of destruction like guns. We should be more quick to do so with other groups that the data would show or have the potential, increased potential of using a gun to hurt you.
Unbelievable data, and certainly an area that most healthcare professionals often don't even think about. So you have really enlightened us as to the role we individually can play to help educate those with whom we come in contact about violence in general, traumatic stress, race-based traumatic stress, generational stress in communities. Disease does not exist in a vacuum. It exists in a socio-cultural community context. And unless you examine all of what involves community, you cannot have appropriate messages, select appropriate messengers, decide on appropriate media. It is all interconnected. And the cultural deficit that still exists and is persistent in the healthcare industry, we've got to change that. We've got to fill it with people like you, Dr. Bailey, who have this years of experience and commitment, and learn from them. No need to reinvent the wheel. There are solutions. They're not easy because the problems are complex. So thank you so much for enlightening us. I have your book. I've read half of it, so it's always on my summer reading list.
All good, all good.
And
I appreciate you.
It's wonderful to know the person who actually authored it. So your insight, your commitment, your passion, and your just clinical expertise goes a long way to helping all of us bridge the gap between violence, health, and community. That's what it's all about. So thank you, Dr. Bailey, for being my guest. It was my honor.
Thanks for having me. It was an honor to be on. Really appreciate it.
Thank you. And that ends this episode of the Kaleidoscope.
You've been tuning into the Kaleidoscope, Healthcare in a Diverse America from Molecule to Market, with your host, Sheila Thorne. You can find more episodes on all the major platforms, including YouTube, LinkedIn, Apple Podcasts, Spotify, and on our website, SheilaThorne.com. Thank you for your positive reviews, comments, questions, and for sharing this show with others.